Bismillah ar-Rahman ar-Rahim. Good morning, everyone. Thank you all for being here today. I will start my presentation about brief introduction about economics and what's the health economics, and I will give small or brief introduction about type of health economics. My colleague Dr. Samah will continue with more detail about the type of health economics. So when people think about health economics, they tend to think about money, how to spend money on something health related. I hope at the end of this session, I can convince you that health economics is rather about choices, how to make choices for something presented to us. The major problem in the natural world is we have a finite number of resources. We have finite number of human resources, material resources, and on the other side, we have infinite number of allocation for what we already have. The typical word used by the economists is scarcity. The same thing is applied for in healthcare sector. We have finite number of physicians, we have finite number of nurses, we have finite number of drug, we have finite number of equipment, and in the other extreme, we have infinite number of allocation. So we have to make choices. And it's clear that we cannot respond to everything is being demanded. That's why we need to make prioritization. We have to make choices. Health economics helps us to inform these decisions, but does not make decision for us. It tells us what could be the optimal allocation of decision, and based on some interpretation, you make the choice. The problem in healthcare sector, health spending are continue to grow faster than the economy, and no one can say stop for healthcare expenditure. And this put a lot of pressure on the government in each country. How to solve this exercise? Actually, there are many reasons. Aging population, extension of universal health coverage, and emerging of a new health technology. And we know if we make decision, there is opportunity cost for each decision. So if we have budget 10 million, and if we allocate 3 million for oncology product, this means 7 million is left for all disease. So there is high opportunity cost for each decision. So we have to make choices. The other thing is that in Jordan, we have commitment to implement universal health coverage. The outer cube is the ideal one, and the inner cube is the current situation. And there are three dimensions or different moving parts in this cube. The first one is population is covered. Everyone should have access to health care, and the health care he needed. I am saying need, not want, because according to literature, approximately 20 to 40% of healthcare expenditure are going for wastage, and this wastage comes from want rather than need. Additionally, the healthcare should be in adequate health services, and everyone, as I said, everyone should have access to health care he needed without becoming poor or even poorer. So we talk about two things here: access to adequate health care services, and the second item is financial protection. The most important thing, which is basket benefit, what should be in the basket benefit? Because, as I said, it's clear that we cannot afford all available effective treatment for everyone. So we have to make prioritization. What should be in the basket benefit? Actually, Jordan has national and international commitment to implement universal coverage, or to be more accurate, to move universal health coverage, because in theory, no country can achieve full universal health coverage. Because every day we have a new emerging disease, we have new emerging technology, so we have to reprioritize other previous decisions. Question for decision maker. The first issue in health technology that is there is uncertainty in healthcare, because if there is no health gain, then forget it. So if there is health gain compared to placebo or compared to current treatment. And then the next question is is it good value for money? We compare incremental cost and gain. And this is why do we need full economic evaluation. So if we evaluate only benefit, it's not sufficient to justify reimbursement decision because we could running out of the budget. And if we evaluate cost only, maybe we will violate patient safety. So that's why we need to evaluate both cost and benefit for at least 2 alternative treatment. This is the diagram show a new therapy with alternative treatment. And in each route, we compare both cost and the impact on health status. And at the end, we take the ratio and we conclude with the ISAR. We should have something called threshold or willingness to pay, how we are willing to pay per equally gain or per daily averted or per life year gain to say this is cost effective or not. For the type of health economics evaluation, the first thing is cost minimization analysis. The cost minimization analysis, we have 2 drugs within the same disease area with equivalent outcome. So in this type, the benefit should be identical to enable to use this type of cost minimization analysis. So it's, we can choose between technology with equivalent outcome. The problem in this type of cost minimization analysis, we need strong evidence to prove the identical and health outcome. So we need non-inferior trial, and decision will be based on cost difference. This is what's called the cheaper the better. I think this is used currently in GBD. And the typical example for this is a brand versus generic drug. The second item is cost effectiveness. The benefit in natural unit, millimeter mercury, for example, and survival. And we have different outcome in same disease area. We have different technology in same disease, for example, in blood pressure, we have different drug, and we can compare these drug together and choose between technology within the same disease area. The problem in this way, we cannot compare apple to orange. How to compare a drug within hypertension disease with a drug within diabetes mellitus, because we have different outcome in this. In this way, we can use so-called cost utility analysis, because benefit, we can evaluate benefit inequality. This is quality adjusted life year. And we can choose between different therapy in healthcare system. So we can compare between different drug in diabetes and hypertension. Then we can, for example, inform decision for insurance package in this way. And the decision again based on ratio, so-called ISAR, different delta cost and delta quality. And the last one, but not least, this is cost benefit analysis. And this is at the allocative, at the macro level. Think about currently we have COVID-19 pandemic, and we have very low budget. And the Prime Minister is asked to allocate money to building a new hospital or to building or to reconstruction the highway. The decision has come now. And you know, we cannot compare the outcome in healthcare sector with, for example, with the Ministry of Education, so we need, the benefit will be evaluated in monetary value. So cost benefit enable us to choose between program and different health sector of the economy.
Excuse me, Dr. Emad, you have 2 minutes.
Investment decision in this type, this is so-called payback period, net present value. As I said, building hospital versus highway decision. Thank you.